Hey guys, this presentation will be on PTSD, Post-Traumatic Stress Disorder, how to diagnose, what history and exam you should do, investigations, and treatment. So, presentation. A 35-year-old female presents with severe symptoms of anxiety, irritability, and difficulty concentrating, which have been present for the past 6 months since her involvement in a motor vehicle accident. What additional features would need to be present for a diagnosis of post-traumatic stress disorder? What are the essential components of psychological treatment for this disorder? So, provisional diagnosis is that she has post-traumatic stress disorder. The DSM-5 criteria in order to diagnose PTSD requires 6 criteria. They need one or more of the first set experience, one or more of the 7 set re-experience criteria, avoidance of stimuli associated with the trauma and numbing of general responsiveness, and negative alterations in mood and cognition, and alterations in arousal and reactivity. And finally, it has to have a significant impact on social and interpersonal relationships and should not be attributed to an organic cause. So, having one or more of these following symptoms is for the first criteria. So, this is for the first set experience, so the actual traumatic event, that they either directly experienced it themselves or they witnessed it happening to others. Alternatively, it could be that they learned about the traumatic experience that happened to a close family member or a friend, or experienced repeated or extreme exposure through the details of the traumatic event, not on TV, movies, or pictures. They need to have one or more of the following criteria for their second set re-experience. So they have thoughts or perception, images, nightmares, illusions or hallucinations, dissociating flashbacks, intense distress to cues that symbolize some aspect of the event. They need to avoid stimuli associated with the trauma and numbing of general responsiveness. Negative alterations in mood and cognition include inability to remember an important aspect of the event. They have persistent and exaggerated beliefs about self, feeling detached from others. There are alterations in arousal and reactivity. They can become hyperaroused, have an irritable behavior, have angry outbursts, reckless or self-destructive behavior, concentration problems, sleep problems, hypervigilance. In children, there may be a different reaction to the trauma, and their behavior may be marked by separation anxiety, persistent crying, screaming, and whimpering, and excessive clinging. In some, there may be a regressive behavior, extreme withdrawal, and poor concentration. I apologize for my dog barking. Significant impact on social and interpersonal relationships should not be attributed to an organic cause. So in terms of history, you want to take a history of their symptoms, any risk factors for PTSD, and a risk assessment. So for symptoms, you want to ask about the trigger and what happened. And don't be surprised if they can't tell you, because these patients often report forgetfulness regarding the traumatic event. Or trauma that is inflicted by other humans is the worst kind of PTSD. The duration is more than 1 month, and also screen for other PTSD symptoms. They may have somatic complaints, sleep, or concentration problems. In terms of risk factors, it's important to ask, are you nervous by nature? Because having neuroticism before the trauma increases the risk of having PTSD. A history of them having prior trauma or abuse, psychosis, mood disorders or anxiety disorders, and having drug and alcohol problems. Also do a risk assessment for any psychiatric history and assess their harm to self, others, absconding, and neglecting children. Psychosocial, ask about work, school, finances, relationships, and legal issues. In terms of the examination, you want to do a mental state exam, which looks at their appearance, behavior, speech, mood, affect, TFTC, perception, cognition, insight, and judgment. So usually these patients may look disheveled or lacking self-care and hygiene. They may be agitated or hyperaroused. Their speech may have a poor rate and flow, and their mood may be altered. Also do a physical exam to look for any physical injuries associated with a traumatic event. For example, bruises or cuts on the victims for those who have had experienced domestic abuse. In terms of management, it's important to use a multidisciplinary approach and the biopsychosocial model. Management can be divided into non-pharmacological and pharmacological, with the most effective being non-pharmacological. This includes psychoeducation, CBT, EMDR, which stands for eye movement desensitization and reprocessing, treat comorbid substance abuse such as alcohol illicit substances, and group therapy. In terms of pharmacological, first lines are SSRIs and TCAs. For those who have hyperarousal, you can give them clonidine and beta blockers to reduce their sympathetic drive. For improved emotional regulation, antipsychotics at a low dose, such as quetiapine. And if they're undergoing an acute attack you want to calm them, benzodiazepine in the short term or mood stabilizers in the long term. In terms of psychoeducation, this needs to be both towards the family as well as the patient and also the GP. Try and get the GP on board with the education, especially if they were the one who provided the timely detection of the condition. Cognitive behavioral therapy should be done by an experienced practitioner. You would want the patient to recall the trauma, and the patient undergoes a prolonged exposure to the event. Recording the patient's most traumatic memory, asking the patient to listen to it over and over again in order to contextualize the memory and prevent it from triggering an autonomic or nightmare response in the future. So this is kind of like a desensitization. The next one is EMDR, eye movement desensitization and reprocessing for post-traumatic stress disorder. And this therapy has shown that the mind can in fact heal from psychological trauma, such as the body healing from physical trauma. It basically tries to identify the target memory or belief about a trauma. And then as the patient records it, you want them to focus on hand movements or tapping. And the eye movements makes it easier for the patient to tap into the memories so that they become more easily recorded and more easily analyzed. So it's an 8-phase process. So phase 1 is when you have history taking sessions in order to identify what event may have triggered their PTSD. Phase 2 is to teach the patient imagery and stress reduction techniques so that they can use this during and between sessions. Phases 3 and 6, the client is instructed to focus on the image, a negative thought, and body sensations, while simultaneously engaging in EMDR processing using sets of bilateral simulations, such as eye movements, taps, or tones. Then you ask the patient for their mind to go blank and notice whatever thought, feeling, image, memory, or sensation comes to mind. Phase 7 is that they have a logbook over the week, and Phase 8 is examining processes thus far and planning for future, and then going all the way through Phase 1 to 7 again. So EMDR, the reason why it works is many people believe that it's connected to the biological mechanisms involved in rapid eye movement sleep, so that internal associations arise and the clients begin to process the memory and disturbing feelings better when they have something that causes them to move their eyes around or to shift their focus. And successful EMDR therapy, the meaning of a painful event is transformed on an emotional level. For example, a rape victim shifts from feeling horror and self-disgust to holding the firm belief that I survived it and I am strong. Pharmacological treatments. These are not as effective as non-pharmacological treatments, but if the patient has some of these symptoms, they may be useful as adjuncts. So first line, SSRIs or tricyclic antidepressants. If the patient has hyperarousal, clonidine or beta blockers. For improved emotional regulation, antipsychotics low dose such as quetiapine. Acute attack or you want a calming effect, benzodiazepines in short term and mood stabilizers in the moderate long term. Some additional questions that you may be asked about PTSD. What is acute stress disorder? So it was introduced in DSM-4 and it refers to an acute reaction after trauma exposure, less than 1 month of the incidence. In contrast to PTSD, acute stress disorder emphasizes on the dissociative symptoms, being out of touch and depersonalized. You can think about it as pre-PTSD. Some of these patients go on to develop PTSD, but in its criteria, you need to have had it for more than 1 month. So it is a strong predictor of those who will suffer from PTSD in the future. So it's important to keep an eye out for acute stress disorder and also PTSD. What causes PTSD? So PTSD is believed to be a dysregulation of numerous complex neural pathways involved in the perception and reaction to stimulus. It arises due to an inability to switch off the threat alarm, and it allows traumatic memories to live on without appropriate contextualization. What is a clinical course of PTSD? So, symptoms occur immediately after the trauma exposure, and many people have a rapid improvement in the first few days and weeks following the event. However, 10 to 25% of patients will, in the long term, develop PTSD. And those who have PTSD, they can be treated. And the time to remission of PTSD is usually after 4 years, using the non pharmacological and pharmacological approaches I talked about earlier. So, thank you so much for listening